Greetings. I am Rakia Selman, an epidemiologist investigating the maternal mortality in Afghanistan. Defining the problem. The issue of maternal mortality in Afghanistan is that an abundance of women and girls are experiencing complications such as postpartum hemorrhaging, obstructed labor, and infection that causes death during pregnancy or childbirth. The maternal mortality rate in Afghanistan was 400 per 100,000 live births. Compared to the lifetime risk of maternal mortality in the United States, which was 1 in 3,500, the lifetime risk for maternal mortality in Afghanistan was 1 in 7. Only 9% of women were assisted by skilled birth attendants, and 8% received prenatal care. The social determinants of health. These social determinants of health are contributing factors that influence health. Social determinants of health regarding maternal mortality is related to social injustice, which has taken a major toll on the health of the population in Afghanistan, especially women. Addressing limited health care, Afghan women do not have access to family planning services, delivery, and postpartum care. Furthermore, there are only 2 midwives that are available per 1,000 births. There are 90 comprehensive emergency newborn care facilities with over 1 million total births per year. And there are about 500 birth complications that occur per day due to limited healthcare workers and limited resources. The social determinant of health for education. Education in Afghan women is limited. 93% of women who died due to maternity-related causes were illiterate. There are less than 5% of pregnant women in Afghanistan that had ever attended school. Only 6% of women 25 and older have a formal education. And studies show that higher levels of education were associated with lower rates of hemorrhaging complications during pregnancy. In addition, there are some sociocultural practices. Afghan women face societal practices such as early marriages, rights surrounding sexual practices, and the need to obtain their husband's permission to receive health care. They also face judgment from their mother-in-laws that are resistant to institutional delivery. These families want the support of women, but there are a shortage of trained health workers in Afghanistan and a high unmet demand for female physicians, nurses, and midwives. Pregnant women and women in Afghanistan tend to have a lower income and are poor, and they cannot afford the health care services that may be provided or available. And then also, wealth was the strongest determinant of a skilled birth attendant being used during childbirth. Another social determinant of health is malnutrition, which is the lack of food that contributes to an increased risk of complications among pregnant women. The social ecological model, which is a model that illustrates personal and environmental factors that impact health. My social ecological model illustrates the factors that help and hinder maternal mortality in Afghanistan. So as you can see, the model has different levels. There's the individual level, intrapersonal level, and organizational level. As far as the factors that help on an individual level, it deals with religion. And religion states that and promotes that 30 months should be between births. But women of childbearing age are more likely to be poor, and that hinders maternal mortality. On an intrapersonal level, there is an initiative to household counseling that is there for support for pregnant women and their mother-in-laws. However, there are also cultural barriers that hinder this process because there's limited knowledge of family planning and contraceptive use. On an organizational level, there are different organizations with training programs in a hospital setting in rural communities that provide training for midwives. But on the other hand, there are limited medical supplies and resources that cannot be used or are not available to be used. On a community level, there's a dissemination, distribution of misoprostol that will help in reducing hemorrhaging. Yet, community leaders are resistant of women getting employment and education. And on a policy level, there are different activities and training that help with neonatal care and strengthening the policies of family planning and reproductive services. However, when Afghanistan was over the Taliban government, that restricted women from having any control over their own bodies as well as any reproduction. The evidence-based intervention 1 deals with misoprostol, which is a drug that reduces postpartum hemorrhaging or blood loss experienced during childbirth or pregnancy. And the community health workers would administer the drug to women who are giving birth at home or low-quality facilities so they can reduce the loss of blood experienced during childbirth. The second evidence-based intervention deals with a system called tele-emergency assistance, which is also known as T, and that helps midwives get the support that they may need from experienced midwives or physicians that are available via mobile device technology. So they have the service where they can call in for support during severe complications that may occur. But also midwives or people being interested in being a midwife would attend an educational program to become trained by the expert midwives to know what to do and the different methods on dealing with the severity. And the evidence-based intervention 3 deals with the calcium supplements that will reduce hypertensive disorders such as preeclampsia and eclampsia. The evaluations of the interventions deal with the first intervention, which deals with the misoprostol. You just assessing the amount of the drug that's given per delivery per woman to reduce that blood loss. Also with the T system to assess and monitor the number of pregnancy-related complications and the amount of support provided per day. The calcium supplement hypertensive disorder, we're looking at assessing and measuring the hypertensive condition of the pregnant woman prior to the supplement and then monitoring after each day. There are different barriers, potential barriers and solution, again, based off of family support and the things of husbands and mother-in-laws, and then also our midwives, and we need money to fund different things. So the solutions to that is the opportunities for mothers and infant development, low-cost programs, and the different midwife programs. Here is the logical model that demonstrates the inputs, which deals with the different providers, educational programs, as well as the activities, the outputs, outcomes, and the impact. And the overall impact is to reduce maternal mortality. These are my references. Thank you.